Okay, now coming to megaloblastic anemia. Anemia, I will be covering iron deficiency anemia and megaloblastic anemia. So, definition, causes, pathogenesis, clinical features, investigation, complication, treatment, and differential diagnosis. We will discuss that. So, what is anemia? It is mainly a decrease in the hematocrit or volume of PEG cell RBCs. So classification of anemia according to the cause is can be classified into hemorrhagic, hemolytic, aplastic, or nutritional. According to size and hemoglobin concentration, it is divided into normocytic, normochromic, microcytic, hypochromic, or macrocytic, hyperchromic. So normocytic, normochromic size and content will be normal. Microcytic, it will be decreased. Macro, it is increased. So normocytic, it can be due to chronic infections or CKD. Microcytic, iron deficiency and thalassemia, and macrocytic due to B12 and folic acid deficiency. So we will discuss today with B12 and folic acid deficiency, megaloblastic anemia. So these are the approaches. So this is the normal RBCs, and it is defective hemoglobinization leads to there is defective hemoglobinization, though normal DNA synthesis. So it is iron deficiency and thalassemia and sideroblastic are the examples. There will be decrease in MCV leading to macrocytosis, and there is defective DNA synthesis leading because of B12 folic acid deficiency or myelodysplasia or cytotoxic stress. There will be normal hemoglobinization unlike in iron deficiency anemia. So it is usually seen in B12 and folic acid deficiency. So by definition, megaloblastic anemia, as the name suggests, the size of the RBC will be large. There will be nuclear dysmaturity, impaired DNA synthesis. It is caused by B12 folic acid deficiency or few inherited disorders of pyrimidine synthesis or inherited disorders of DNA synthesis or syndromes like Nash-Nihan. So pathogenesis, as I told you, there will be impaired DNA synthesis leading to ineffective erythropoiesis and production of abnormal RBCs. Nuclear cytoplasmic asynchrony will be there. So role of vitamin B12 and folate in DNA synthesis, homocysteine is methionine is made from homocysteine with the help of vitamin B12 as a catalyst, and UMP is made to thymidine monophosphate by thymidine synthetase in the presence of tetrahydrofolate. So what are the causes of deficiency of B12? They can be decrease in intake, impaired absorption, increased requirement, or impaired utilization. The complications of B12 deficiency may include, which is one of the dreaded complications, being subacute combined degeneration of the spinal cord, which leads to demyelination. There will be loss of senses or proprioception. There will be distal sensory loss, exaggerated knee jerk, absent ankle reflex, and extensive plantar. Other clinical features include hematological manifestation in the form of anemia, neurological manifestation in the form of irritability, convulsion, mental retardation, position sense loss, and vibration sense loss. There can be some psychiatric manifestation, and in a malnourished child, we can see hyperpigmentation of the knuckles, glossitis, and stomatitis. Investigation, we should go for CBC with complete blood picture with peripheral smear. So in megaloblastic anemia, there will be decrease in RBCs leading to decrease in hematocrit. The size of RBCs will be increase in MCV, and hypersegmented neutrophils will be there, and homocysteine will be there because there is no vitamin B12 to convert into methionine. For diagnosis, there will be significant macrocytosis with MCV more than 100, MCV more than 110. It confirms the megaloblastic anemia. There will be low retic count, decreased leukocyte and platelet count can be there, marked anisopoikilocytosis. So here you can see hypersegmented neutrophils. So these are the megaloblasts with hypersegmented neutrophils. Other biochemical analysis apart from CBC and PS comment, we can go for serum and red blood cells, folate levels, B12 acid, LDH, homocysteine levels, which will be increased. Others like Schilling test and other acid excretion tests, and lastly jejunal biopsy. Bone marrow study we can go for. Treatment include vitamin B12 lifelong, 100 microgram. If there is severity is more, we can go for 500 to 1000 microgram. Now, other cause of megaloblastic anemia is folate deficiency. Again, the causes are same. There can be decreased intake, increased needs, impaired absorption or impaired utilization, and increased losses. Clinical features include anorexia, weakness, irritability, chronic diarrhea, ulcers, glossitis, impaired immunity and hemorrhage. Treatment, folic acid 0.5 to 1 milligram. Another term is pernicious anemia or Berman's-Addison's disease. It is due to impaired B12 absorption due to the lack of intrinsic factor, and which is due to loss of parietal cells in the stomach. So there can be changes in the alimentary tract, CNS, and bone marrow, which can be hypercellular. Clinical features include sore tongue, paresthesia, weakness, clumsiness, unsteady gait, spinal cord involvement. Investigations include serum parietal cells and intrinsic factor antibodies or gastrin test. Treatment, there will be lifelong B12 deficiency, and it can be given B12 replacement 1 to 2 milligram per deciliter. Higher doses. Complications include gastric cancer, carcinoids, permanent neurological damage. Differential diagnosis of this pernicious anemia include aplastic anemia, iron deficiency, and hypothyroidism, MDS. Thank you. Now coming to iron deficiency anemia. It is high prevalence because of the limited stores at birth, timing of umbilical cord clamping, timing and type of complementary food introduction, frequency of infection in children. In adolescent, there is higher requirement. So iron requirement, usually iron is released from senescent red cells during first 8 to 12 weeks of life. It is stored in the body and has to maintain erythropoiesis up to 4 to 6 months in normal term infant, but up to 2 to 3 months in LBW infants. Normal infants at birth have 75 milligram of iron per kg body weight. So factors protecting infant from becoming iron deficient is exclusive breastfeeding for 6 months, placental transfusion to newborn immediately after birth, when cord is allowed to pulsate before it is clamped, delayed clamping, preferential delivery of iron to fetus during pregnancy. So what is the importance of iron? It is essential for various metabolic reaction in transport of oxygen in the form of hemoglobin and myoglobin, the storage from ferritin and hemosiderin. There are two forms of iron, heme iron and non-heme iron. There are few factors that affect the absorption of the oral iron. The factors enhancing is vitamin C, ferrous salts instead of ferric, citric acid, gastric secretion, acidic pH. So this is the body cycling of the iron. Transferrin, it is the transport protein for iron. Daily diet contains 10 to 20 milligram of iron, which is absorbed and used in the erythropoiesis. Etiology, the decrease in iron stores can be seen in preterm small body twins, or it is due to delayed intake or absorption like delayed weaning, malnutrition, poor iron diet, malabsorption syndrome, and chronic infections. Celiac disease, severe prolonged diarrhea, ischemic bowel disease, few GI surgeries, or it can be due to increased losses, postnatally hypersensitivity to cow milk, allergy to cow milk, gastritis due to drug soapworm infestation, or there is gut anatomical abnormalities, malaria, infections, peptic ulcer, bleeding diastasis, chronic diarrhea can lead to deficiency of iron. It can also be due to increased demand during prematurity, adolescence, in cyanotic CHD patients, malnutrition. So how control of erythropoiesis takes place? There's hypoxia, which stimulates liver and kidney, leading to secretion of erythropoietin, stimulation of bone marrow, increased RBC count, accelerated erythropoiesis, and increased oxygen transport. Clinical features include, initially there will be pallor, anorexia, and irritability with the patient come with this complaint later. Patient may complain of palpitation, shortness of breath, fatigue, and reduced exercise tolerance. Signs can be pallor, angular stomatitis, glossitis, cholonosia, tritinosia, abnormality in the nails. This is pallor, lower palpable conjunctiva. This is spoon-shaped nails. This is tongue without papillae. This is cheilosis or stomatitis. Pica can be seen in such patient. Blue sclera can be seen. Usually adolescent, school-going children We have seen decreased mental and physical functions with impaired performance at the school. Investigations in CBC, we can see hemoglobin, there will be decrease in hemoglobin, RBC count, hematocrit, MCV, MCH, and MCHC. Apart from that, in peripherals, we can see hypotomia, microcytosis, poikilocytosis, target cells. Here we can see absent iron stores in iron deficiency anemia. Now, WHO grading of anemia between 10 and the cutoff for the age, it is mild, 7 to 10, it is moderate, less than 7, it is severe. In conjunctiva and mucous membrane, it is mild, skin and appendages, moderate, palmar is severe. Coming to differential diagnosis, it should be differentiated between by thalassemia trait, where mild microcytic anemia with elevated hemoglobin A, anemia of chronic illness, it is normocytic, normochromic, lead poisoning, basophilic stippling will be there. Management constitutes of correction of anemia, eradication of underlying cause. Oral medication, it is so safe, economical, easily tolerated, effective, and ideal. It is given by the maintenance dose of 3 to 6 milligram per kg per day for 3 months. For adolescents, 60 milligram per day. Mild anemia for moderate to severe, 120 milligram per day. One program is also there recommended by India, it is National Nutritional, at national level, National Nutritional Anemia Control Program. So the response to the iron therapy in first 24 hours, there will be subjective feeling of goodness, okay, improvement. In next 2 days, marrow response will be seen. In next 3 days, reticulocytosis will be seen with peak at 5 to 7 days. Depletion of stores take 3 months. Parenteral iron is indicated when there is intolerance to the total iron, persistence of non-compliance or GI bleeding. Iron dextran is used. Thus, blood transfusion should done. Transfusion therapy is indicated in severe iron deficiency case, should be avoided in young and stable patients.